Welcome, everybody. General Schmidt, I would like to have you go ahead and get us started.
Very good. Well, thank you, everybody, for participating in this webinar today. I'm Derek Schmidt. I'm joining you from Topeka, Kansas, where it's a beautiful January day, words that don't always go together out here. I want to thank CWAG in particular for pulling this webinar together. It's great to be partnering with CWAG, between CWAG and NAG, with respect to this subject matter that is hand-in-glove part of our NAG presidential initiative this year that deals with protecting seniors and combating elder abuse. As part of that NAG discussion, we had at the end of last year a panel discussion that related to drug pricing. And today's webinar is an opportunity to take that discussion a bit deeper. Titled, of course, Combating Rising Drug Prices for Seniors. We'll be focused today with some exceptional panelists on some of the dynamics that drive the marketplace and that ultimately affect seniors' ability to access needed medications. Let me make one necessary housekeeping announcement. Then I'll introduce our three panelists and I will turn this discussion over to them. First, on the housekeeping side, for all attendees, we will have a session for questions at the end of the webinar. For those of you who are participating online, you may use the chat screen to send your questions in, and CWAG will address your questions at the end of the three presentations. This webinar is being recorded, and a viewing link will be sent out after this session. So if you have any questions, send them in, and Lauren will provide that they be posed to our panelists once they've completed their initial presentations. With that, let me introduce our panelists today. Panelist number one, and the first who will speak at the end of these introductions, is Jeff Francer. Jeff is Senior Vice President and General Counsel of the Association for Accessible Medicines, where he leads the legal and international trade advocacy for the organization. Jeff served as Associate Chief Counsel of the Food and Drug Administration from 2003 to 2005, where he advised agency leaders on issues involving the regulation of drugs and biologics, including clinical investigation, manufacturing, promotion, enforcement, and legislative matters. After leaving FDA, Jeff served as Associate General Counsel, U.S. Compliance Officer, and Chief Privacy Officer of Biogen Idec, Inc. At Biogen Idec, he was the primary in-house counsel on FDA issues, fraud and abuse prevention, and patient privacy. Jeff was also responsible for overseeing the U.S. Corporate Compliance Program. Our second panelist is Kip Snyder. Kip joined PhRMA on October 1 of 2015 and currently heads PhRMA's state policy team. Based in Washington, Kip is responsible for leading the development of PhRMA's policy engagement with state legislatures, governors, and agencies nationally across all major issues affecting the biopharmaceutical industry at the state level. Before joining PhRMA, Kip spent 13 years at Amgen, most recently leading a team of state lobbyists in the U.S. and Puerto Rico. Earlier in his career, he worked in governmental affairs and commercial roles at Pharmacia Corporation and practiced law with Howry and Simon. Kip is a graduate of the College of William and Mary and the George Washington University Law School. He lives in Arlington, Virginia with his wife and three children. And panelist three is Jane Horvath. Jane is the NASHP Senior Policy Fellow. She's an experienced health policy analyst and policymakers. She has a deep background in Medicaid, commercial insurance markets and regulation, as well as Medicare and prescription drug pricing and reimbursement. Before joining her current organization, Jane most recently worked in the private sector as a consultant to life sciences foundations and advocacy organizations. She's held research positions at Johns Hopkins and MacPac. Jane spent 10 years at Merck working on coverage and reimbursement policies and federal programs. She's worked for Medicaid directors, the U.S. Senate Finance Committee, and was the Deputy Assistant Secretary for Legislation for Health at the U.S. Department of Health and Human Services. At NASHP, she works with the Emerging Issues team and is leading their current work to foster state initiatives on drug prices. I want to thank all three panelists for taking time to be part of this conversation and share their expertise with all of our participants. And with that, let me turn this over to Jeff. Jeff, thank you.
Great. Thank you so much, Attorney General Schmidt and members of the audience. It's really a pleasure to be here today. If we could just turn to to my first slide. Really, what I wanted to try to do was to discuss some of the important differences between the brand and the generic drug business models. One thing that I think everyone recognizes is there is a critical role for innovation and for the branded side of the business. However, at an appropriate time, when the branded drugs have had the opportunity to recoup their investments in new medical treatments for patients, that's when we need generic and biosimilar medicines to provide competition. And the good news is that there is an incredible amount of generic and biosimilar competition, and we believe that there will be even more to come in the years ahead. The first of three important facts that I wanted to provide to you just at the outset is that generics now fill 89% of all of our prescriptions in the United States, but for only 26% of the cost, which means that the other 3/4 of the other 10% or 11% of the prescriptions are from the branded sector, which is about 3/4 of the cost of medicines in this country. Second, and importantly, is that generic drug pricing is actually deflationary. Market data from several sources have shown significant erosion over the past 16 months or so in the generic market. And the fact of the matter is that on average, there's about 7 to 9% price deflation in the generic market every year. And that's due to the incredible competition of once you have more than 2 or 3 generic manufacturers competing based on price, the price really falls out of the sky. There's also an incredible amount, and this goes into fact 3, of impact from the 3 large buyers in the generic sector. There are 3 large wholesalers that are buying approximately 90 to 95% of the generic drugs. They have enormous purchasing power, and that is really what is driving the deflation every year. So if we could go on to the next slide, just a little bit more in terms of facts and figures. So we took a look at the top 100 drugs prescribed of generic drugs in the United States, and it averages about 40 cents per dose. If you take a look at the brand side of the equation, you're talking about $13.24 a dose. And so that's really what's driving the costs here, that 11% of the prescriptions in the country are driving 3/4 of the cost, while 90%, as I mentioned before, 3.9 billion prescriptions are costing taxpayers and payers only about 1/4 of the cost of prescription drug spending in the United States. So it's important to know that while there clearly is a problem with drug pricing, that we have a solution that just about everybody agrees upon, Democrats and Republicans, and that is the strength of the generic drug market. Going to the next slide, this is actually data from Morgan Stanley, and it shows that from July of 2016 to July of 2017, so very, very recent data, generic prescriptions increased by about 2% over that time period. During the same time, the number of brand prescriptions decreased from about 7%. At the same time, the generic the revenue decreased by 13%, while the brand revenue increased by 5%. So what we have here is a phenomenon that while the number of generic prescriptions in our country continues to rise, the revenue is actually dropping, and the converse is so on the brand side. And so when you're looking at legislation in the states to protect your citizens against drug pricing, it's important to understand that the price trends show that that there is, incredible deflation now in the generic drug market. If we could go to the next slide, I will say that perhaps the greatest proof that that there is this type of deflation is that Wall Street is sensing it, and the financial writers are writing about it. The Wall Street Journal recently published a story that said that the U.S. generic drug pricing is falling at the fastest rate in years, and interestingly, the deflation in the generic drug market is starting to impact other parts of the supply chain, and that includes some of the wholesalers. AmerisourceBergen and McKesson have both noted that there is this deflation is actually affecting their bottom line. So going to the next slide, one thing that I think can really benefit folks is some transparency, and this slide reflects some data crunching that we did using IMS Health data for the top 100 prescribed generic drugs. Interestingly, if you look at the whole supply chain, on average for these top 100 drugs, the generic drug makers are selling to the wholesalers their drugs at, on average, 10 cents per dose. The wholesalers are then selling that 10 cent per dose to the pharmacies at 12 cents per dose. So on average for these top 100 generic drugs, they're getting on average about 2 cents per dose. If you paid cash at your pharmacy for these same drugs, based on data from GoodRx, you would have to pay $1.47. Now, the interesting thing here is that the generic drug maker only controls that sale for 10 cents. They don't control the sale at 12 cents or the sale at $1.47. Numbers change, obviously, for folks who have insurance. And if you do have insurance, your average out-of-pocket cost for a 30-day generic prescription is $5.54. So I think a couple points here. One, the generic drug maker controls the sale from itself to a wholesaler, number one, and not further down the supply chain. And then secondly, the cost that you're paying at a pharmacy window, if you're paying cash, is a significant markup from the retail side compared to what the generic drug maker sold it to the wholesaler for. And then finally, I think one thing that we can all agree on is that $5.54 average out-of-pocket cost for a 30-day prescription is good news for everybody. And I often tell people, I have 2 little kids at home. They routinely share their viruses and bacteria with me and my wife. So last year, we all came down with strep throat at the same time. I went to the pharmacy, picked up 4 prescriptions of generic amoxicillin. I also bought a toothbrush. The toothbrush cost more than the 4 amoxicillin prescriptions combined. And that really tells us the type of value that we're getting out of the generic drug marketplace. And that is something, as I mentioned, that is a key solution to our drug pricing issue. We don't want to do something that harms the savings that we can get. If we go on to slide 7, I will say that sustainable generic competition is threatened. It's threatened by a combination of anti-competitive abuses, and we've heard more and more, including at the confirmation of the new Health and Human Services Secretary, that there's been an abuse of the patent system and gaming on the brand side, which is delaying, in some respects, generic competition. There's been market consolidation that I already mentioned on the wholesaler side, whereby they are driving price deflation at such a rate that it is actually causing some of the generic manufacturers to go through a lot of financial stress at the moment. And then there have been some policy failures. We, in particular, will point to a bill that passed in Maryland last year, where in trying to get at the drug pricing crisis, the Maryland legislature decided to focus on generic drug pricing. We would tell you that competition and having more than one manufacturer in a market is what drives down prices, and that if you're going to look at legislation that is going to try to bring down prices, you have to look at areas where there is not competition. In other words, where there are sole source providers. We believe that there are some areas where we can all agree on, where we can bring savings. The generic drug market has to be one of them, and preserving it has to be something that we can all agree on. The very last slide I wanted to tell you, and this is a little bit off topic, but AAM, our association, is working with one of the largest suppliers of online education on a prescription drug abuse portal. This company called EverFi does, for example, the bulk of the online training for Walmart. They know what they're doing when it comes to delivery of online education, and they are now providing a course free of charge to colleges and universities around the country on prescription drug abuse. It's something that we're happy to help sponsor, and if you or any of you have any questions about this resource, I'd be happy to provide that information to you offline. But obviously, the issue of prescription drug abuse, and especially opioid abuse, is something that we all have to be concerned about. So with that, I'm happy to stop here and answer questions. So thanks very much.
Very good, Jeff. Thank you. We'll hold those questions till the end of the presentations and then take them together. So let's turn now to Kip Snyder for his presentation. Kip, the floor is yours. Kip, are you there?
Hey, Kip, make sure you're not muted. We can't hear you.
Well, in the absence, Kip, is that you? While we send a search party out for Kip, perhaps we can fast forward to Jane, unless Kip is there. Is that you, Kip? Jane, would you have any objection to going next while we see if we can find Kip?
No. Can you hear me?
I can hear you. Thank you. Whatever you're doing, Kip should do it.
Okay. So, no, I do not have a problem. I do apologize, however. I was sort of thinking I would be the bat cleanup here and sort of respond or comment on the comments of Jeff and Kip. So I'm just going to wing it a little bit, if you don't mind. Do you have our slides up?
Yes, we do.
Okay. So basically, I work now with the National Academy of State Health Policy. We like to call ourselves sort of the UN of state health policy, in that we are sort of a meeting and collaboration space for all different aspects of state government, so legislators, Department of Corrections, Public Health, Medicaid, governor's offices, and on and on. And we bring together all those disparate professional perspectives on solving for some fairly difficult state health policy issues. And I myself am working with a Laura and John Arnold Foundation grant to assist states in thinking through prescription drug cost and pricing policy approaches. So, so if you could just go to the next slide, which this is sort of a description of what we do at NASHB. So if you go on our website, you can find a legislative tracker. We track the legislation that's being introduced that really pertains to drug costs and drug spending. So we don't necessarily track things about pharmacy reimbursement changes or things like that, but things that ultimately have the potential to affect government spending or consumer spending on prescription drugs. And we've issued a report. Our most seminal piece was from October of 2016, and it was 11 recommendations that our state pharmacy cost work group had decided were things they thought states should try to move forward with different options of addressing drug costs. And so the last slide here, and then I'll get into sort of my comments. The last slide here just shows the members of our work group. And you can just see that I sort of characterize them as a geographically, politically, and professionally diverse group of folks that bring a bunch of very different perspectives together to our work here at NASHB in terms of advising us and recommending how to go forward. So with that, I just wanted to make a couple of brief remarks on some of this, and to follow up and I think endorse what Jeff was saying is the industry is extremely complicated. I think it's probably the most complicated industry that there is. There are so many nooks and crannies to it, and there's lots of perverse incentives in every corner of the industry. You know, manufacturers, distributors, dispensers, pharmacy management, Medicaid, you name it, there is some really misaligned incentive. And it's misaligned in the sense of trying to constrain costs, improve health, create access for people to medicines. It is really something very difficult to get into and change, basically, again, because of the misaligned incentives and because of just the sheer complexity of the industry overall. And that's like nobody's fault. It is the industry that has developed over time. You know, way back when there was a court case that said manufacturers couldn't provide differential discounts. And so now manufacturers wind up providing these pretty non-transparent rebates. But there's a reason that the industry looks like that. It wasn't like that manufacturers just chose from Jump Street to go to that place. So it's a whole bunch of things that have stacked up over the decades to create what we're looking at right now. Which leads me to my next point is that it's very difficult for states to figure out how to unravel some of this and how to start to try to align incentives to create affordability, to create access for prescription drugs, to create some predictability in spending. And states are increasingly active on this front, as I'm sure you are all very, very aware. I was just looking at the folks who have registered for this conference, and some of your states are really quite active in this space, legislatively and administratively, as far as I am aware. But given the Byzantine nature of the industry and the case law in particular that has developed over time, particularly around patent law and case law decisions, federal court decisions, the Commerce Clause, and more specifically the Dormant Commerce Clause and some of the case law around that, and then, of course, obviously how that all stacks up around the Supremacy Clause. So you think, well, why can't we just do X? Well, you can't really do X because of sort of the very wild nature of the case law that has developed over time. So some of the most sensible things that you would think that people should do cannot be done because states will wind up in court and probably on the losing side of the argument based on a lot of what has preceded any particular state action at this point. So states are looking at some of the more convoluted approaches and some of the approaches that you think, well, why are they doing that? Like transparency legislation may not be all that effective in bringing down costs, but it's a place to start. And if you were to design it well, potentially you will be successful in beating back industry challenges, legal challenges around it. But it's a process where I think states are learning. We here at NASHB are learning and really looking hard at state policy levers set against sort of all the existing case law and where there are vulnerabilities, and trying to develop sensible policy solutions that are not very vulnerable to legal challenges. And it's a trick. It is definitely a trick. But right now we see states mostly looking at, and actually as you know, the legislative sessions have just started, but we're seeing a whole bunch of transparency legislation being dropped, some of it going in new directions, a lot of it following California SB 17 that passed last year. We're seeing price gouging like Maryland, sorry, Jeff, but different generic price gouging legislation in the same model as Maryland. We're seeing some states that are proposing importation from Canada, trying to use the existing federal framework, which actually there's a very small window there that would actually allow the Secretary to permit a program of wholesale importation should it meet certain criteria. So we see some states, and I think we're going to see more states in the next couple of weeks, introducing legislation to try to pursue that avenue as well. And you may think that's crazy, and it may be, but again, given the tools and the limitations on the tools that states have to work with, that's where they're going. We're also probably going to see Maryland introducing a rate-setting bill in the near future, building on their hospital all-payer rate-setting system, and I think other states are going to go in that direction too, because ability to set reimbursement rates is fairly well established across all the states. So those are some of the things that states are thinking to do this year, and I think we're going to see more and different creative approaches among the states, and a lot of it won't pass this year, but I think it's creating a discussion and creating a knowledge base at the state level that will allow really good policy to proceed in future years on the legislative front. And then we're seeing states initiating things on the administrative front, trying to create unified formularies or multi-agency purchasing, if you will. California is looking at that, trying to negotiate, basically stand in as a PBM or bring a whole bunch of covered lives to a PBM under conditions more favorable to the state agencies than they might otherwise get. And Delaware is trying to create a system of unified formularies across some major state agencies, again, so that they have more clout in dealing with manufacturers and are going to be able to drive market share in ways that they haven't been able to before. And you have the New York situation where they've actually just placed a price cap, spending cap. If the Medicaid spending on prescription drugs is projected to exceed X, then there's a whole series of policy activities that are brought to the fore, including identifying the drugs that are quantitatively thought to be responsible for driving the spending and moving the state toward the spending cap. And then trying to negotiate supplemental or maybe supplemental on top of supplemental rebates for the state, and failing that, then they have directed their Drug Utilization Review Board, which every state has attached to their Medicaid program, using that board to assess the value of the product relative to its price, and then go back to the Medicaid agencies with a target supplemental rebate amount. So that, that's a really creative approach too. Colorado is looking to set up a payment system in Medicaid for physician-administered drugs, trying to really get at acquisition cost and reimburse on acquisition costs there in Colorado. So again, a lot of creative stuff going on, and what is ultimately successful and what is ultimately replicable among the states is yet to be seen. But there is a whole bunch of activity going on.
Very good, Jane. Thank you for that and for stepping up in the sequence here. I believe Kip has rejoined us now. Kip, is that true?
That is correct. Can you hear me okay, General Schmidt?
Indeed, I can. I suspect others can as well, and so I'll turn it over to you for your presentation.
Thank you. I apologize for the snafu. I won't dwell on it other than to say I've done a large number of these webinars, and I've never had happen to me what just happened, which is just when it was being handed over to me, the screen on my office phone went blank and it turned off. But I'm glad to be back on, and I'm sure it was awkward, and everybody thought I had my mute key on and was talking ad nauseum, but that was actually not the case. So to get into it, just a quick thread on who it is I work for and represent. PhRMA, of course, is the Pharmaceutical Research and Manufacturers of America. So we represent the innovative, research-intensive manufacturers. We have about 30 members, and most of these are the established, mature companies with the names that you've heard of. And we've actually recently revised our membership criteria to make the requirements for focus on research and development investment even more stringent. Lauren, if you can go to the next slide. I want to start by highlighting some data on the role that biopharmaceuticals play in terms of overall healthcare spending in the United States. And right now, if you look at overall expenditures, retail pharmacy comprises about 10% of the overall spending. And if you were to back up and go way back to 1965 and you were to ask what was the percentage that drug spending comprised at that time, the answer would have been about 10%. And if you look forward in the out years to what the actuaries are predicting in, say, 2025, the answer the percentage is still about 10%. Now, that 10% is in the retail pharmacy channel. If you add in utilization in other channels, such as in physician offices, hospitals, and clinics, and so forth, the number goes up to about 14%. That's the top of the bar graphs that you see. And these are national data across all payers, and so the percentages are higher in some commercial spaces, and they're actually lower in Medicaid programs where the federal Medicaid rebate statute holds costs way down for states and protects them against any price increases that are greater than CPI. If you want to go to the next slide. So keeping in mind in the big picture, seeing some duplication on my screen. I don't know if you all are seeing it, but I'll keep going. If you look at all the components of the U.S. healthcare spend, and you think of them as a pie chart, and drugs are, again, 14% all in all channels, the key point is that the 14% sliver of that spending pie, so to speak, is the piece that's best positioned to make the entire pie smaller. And you can see that happens because prescription drugs can help keep patients out of the hospital, help manage chronic disease, which is actually the real cost driver in the U.S. health system. And this slide in particular examines data in 4 diseases that are huge cost drivers for us: congestive heart failure, diabetes, hypertension, and high cholesterol. And it compares patients who are actually adherent to their medicines versus those who didn't take them as directed. And what it shows is that when patients take their medicines, whether branded or generic, non-drug medical spending goes down and far exceeds the cost of the medicine themselves. If you want to go to the next slide, Lauren. Like we have a little delay, so I'm just going to wait for it to come up. So this slide takes a look at prescription drug spending growth and compares it to overall health spending growth. And this is CMS data on national health expenditures. You can try to get the line graph centered on the screen. I don't know if other folks are seeing it differently than I am. It looks like there's a little bit of a problem with the formatting. There it is. So the flatter line is overall health spending growth. And you can see that's been tracking at between 4% and 6%. So relatively stable going all the way back to 2008 and expected to maintain that trajectory all the way out through 2025. Now, the darker line you see is spending in prescription drugs. And you'll notice there's this big spike in 2014. And 2014 was a unique year for our industry. We saw a record number of new medicines approved, including most particularly phenomenal breakthroughs in the hepatitis C space, where we had new medicines approved that essentially cure the disease. So there was a clear blip in 2014, but what we've seen since then is a normalization. And if you look at the spending numbers in 2016, and these numbers just came in, they were published in the January 2018 edition of Health Affairs, the annualized growth percentage for prescription drugs is just 1.3%. And so, yes, you heard me right. That's not a typo. That's the number. A lot of us who work at pharma are actually considering getting it tattooed on our arms. So I think most folks, when they see some of these data points, their natural reaction is, well, you know, how can this be? Prescription drugs are all over the news, and it's out of control, it feels like, and there's this hedge fund guy, and et cetera, et cetera. So I think that the next slide, if you go to the next slide, really helps to answer the question. And that answer is that when the system works like it's designed to work, and we think in general it works pretty well, though admittedly it's not perfect, but when it works like it's supposed to, products go off patent, and when they do, prices tend to free fall on the major medicines in a relatively short amount of time. And so this slide has a couple of examples of major blockbuster drugs that have gone off patent, and now there are generics available at a small fraction of the cost. And this is what we refer to in the innovator space as headroom for innovation. This is the system we have in the United States where there's true incentive for new breakthroughs, but this is what flattens the curve, is generic competition. So this is what keeps that spending percentage in steady state that I showed earlier at around 14% for now over 50 years. So I think this is the story we as an industry maybe need to do a better job of telling. You see the story on the news when the new breakthrough specialty drug comes out. And yes, it can be expensive, but you don't typically see the one in the story saying, well, Lipitor just went off patent. So if you want to go to the next slide. So this next slide, I'm pretty sure should be my friend Jeff Francer's favorite slide in my entire deck. The key fact worth remembering, and Jeff, you had the same metric, is that about 90% of prescriptions are now filled in the United States for generics. And this slide shows the sales that are subject to patent expiration and generic competition. So you can think of this as future cost savings to the system or as a future boon to Jeff's organization's members. In 2017 through 2021, there's a huge volume of brand sales that are expected to face generic competition. And that data point doesn't even include biologics. When you include biologics, which can now be subject to new competition from what are called biosimilars, the number actually grows to about $140 billion over the 5-year period. So shifting on to the next slide, if you could, please, Lauren. So I want to talk now a little bit more specifically about how drug pricing works. I think there's quite a bit of confusion about this, and it's fueling what, from our perspective, is sometimes a false narrative about drug manufacturers and pricing. The fundamental problem I think we have on this issue is there's a growing gap between the list price of drugs, which is set by manufacturers, and the actual prices that commercial and government payers pay in light of very substantial negotiated discounts and rebates. So let me take just a minute to talk about the role of what we call PBMs, or pharmacy benefit managers. So these are entities, for those maybe not as familiar, that largely exist for the purpose of negotiating rebates from drug manufacturers. And so their clients are insurers and employers. And the way the marketplace has developed and evolved, we now have 3 of them that control about 70% of prescription volume in the United States. So they have huge amounts of leverage and bargaining power. And what they do is they play manufacturers against each other in the marketplace to negotiate the best deals. So insurers and PBMs work together. They create formularies and preferred drug lists. And the manufacturers that cough up the biggest rebates get preferred placement within those benefits and on those lists. And so the insurers and PBMs then decide what patient cost sharing is going to be. So the key point is that for most patients with insurance, the actual out-of-pocket cost is determined not by the manufacturer, but by the insurers and the PBMs. And so what's happened over time is that there's been this growing gap between the manufacturer's list price, which is sort of like the sticker price on a car, and the real actual net price that's paid after factoring in rebates and discounts. And a good metaphor that I've heard on this to focus on list prices, that the list prices are always the ones that are in the headline, but this would be like planning your hotel costs, your lodging costs for your family vacation by using, the rack rates that you see on the backs of hotel room doors instead of the rates that you could get on Expedia or Hotels.com. If you want to go to the next slide, please. Keep hearing a bit of background noise. If folks can mute their phones, be helpful. This slide shows the growing gap that I referenced between list prices, negotiated, or net prices. And I showed you before the modest growth in drug spending, so spending being price times utilization. But even when you just look at price, after you factor in discounts, prices on brand medicines rose just 2.5% and 3.6% in 2015 and 2016, respectively. Again, numbers I think that shock a lot of people, but they reflect the overall system. Yes, expensive new products come to market, but big rebates get negotiated, especially when there's what we call brand-on-brand competition. And meanwhile, other products, older products, prices are free-falling due to generic competition. So the big problem, I think, and I'm going to get into this just a bit more in a minute, is that patients aren't directly benefiting from the discounts, because for the most part, they're staying with PBMs and middlemen and insurers. If you want to move to the next slide. So I want to just quickly highlight on this next slide what I think is a good example of what's going on, which is the new breakthrough drugs that we now have for hepatitis C. I'd referenced how those were launched. They came to the market beginning back in 2014. You can see on the left side of the slide some quotes, and it was as if the sky was falling when these products first came to market. Yes, they were expensive, but keep in mind they cure the disease, so they eliminate the need for liver transplants, for hospitalizations, and so forth. So the quotes you see on the left side from 2014, and then on the right side, and these are all from Express Scripts, which is one of the largest PBMs in the nation. On the right side, you can see what actually happened, and that is that another manufacturer relatively quickly came into the space, created competition. There was brand-on-brand direct competition. As you can read, Express Scripts is highlighting the extent to which rebates and discounts kept the real prices way, way lower than the original list price. So if you want to go to the next slide, just a couple more data points that I wanted to share. Here are some statistics from major payers on prescription drug spending growth. And notice I say growth because, yes, of course, expenditures are going up a bit year over year. Just about everything is, of course, in the healthcare space is rising naturally as the baby boomers age. But the point is that even by these organizations' own numbers, the growth is modest. And comparing 2015 growth to 2016 growth, the rates are actually declining. So if you want to go to the next slide, this is my final slide. I just want to use it to really wrap up my comments by focusing on the patient and the patient perspective. And so remember, it's the insurers and the PBMs who are getting manufacturer rebates, and they're setting up patients' drug benefit structures and deciding, does the patient have to pay a deductible on this claim, or a co-payment, or a percentage co-insurance, or some other sort of cost sharing. And for whatever reason, relative to other areas in healthcare, such as doctor visits or hospitalizations, patients are being required to pay a disproportionately high share of cost sharing for prescription drugs. And I think the most troubling part of this is you look at the numbers that 52% of the expenditures that were made in cost sharing by patients for prescription drugs were based on the full list price. So that back of the hotel room price. And we're familiar with, there's been a sort of a change that used to be that co-payments, flat dollar co-payments sort of ruled the day, $10, $25 you'd pay when you went to pick up a prescription. Increasingly, we're seeing co-insurance, which is where the patient pays a percentage of the price. So, 25%, 50%, whatever it is. The key takeaway is that the way the market works, that in almost all cases, that 25% or 50% co-insurance is being multiplied times the full list price and not the greatly discounted price that the insurers and the PBMs are getting. So from our perspective at Pharma, we think that doesn't feel right. We've been talking a fair amount, very openly about this and trying to educate consumers, regulators, and the public on how the system works. So I will wrap up my comment there, and I'm sure we can have some time for questions. Thanks a lot.
Very good, Kip. Thank you very much. I'm going to slightly deviate from our set schedule and give Jane an opportunity, if she wishes, for what we'll call a further statement, since she'd originally planned on going last. Jane, do you wish to do that, having heard Kip's presentation, or no?
Yeah, actually, I would. I would just like to clarify a few things about the data, if I could. It's important when you see information about prescription drugs as a percentage of health expenditures, that is, in fact, sort of what the CMS actuary puts out every year. And it's all health expenditures. It's NIH research money. It's all health expenditures. And I think what's driving the debate in states right now is the fact that when you look at employee health benefits, be it state employees or be it, the commercial private companies in a state, prescription drugs as a percentage of the total package of health benefit spending for employees is anywhere from 22 to 25%. And so that's a big chunk. And Kip is right that, these medicines do, in fact, diminish other spending. They are offset by reductions in other spending, but it's a very different number and, creates a whole different set of policy considerations. And I also wanted to say that when the system is working well, as Kip had said, like when expensive brand name products go to generic and create this headroom for innovation, the sort of problem that we're seeing there in the policy space is that there are so many patent extensions going on. And that, that makes the system not work well and creates, again, this policy discussion that we're having. I totally agree on what constitutes working well. And then the bottom line is that there are, massive rebates floating around in the system at this point, and it gets back to what I was talking about, the extreme complexity of the market, this marketplace, and the perverse incentives sort of in every corner of it. But list price is important. List price is sort of what's driving the discussion. And everything that Kip mentions about sort of the PBM role and patient affordability through the benefit design of insurers, that is all absolutely worth discussing, but also list price is worth discussing.
Very good. We've now heard the presentations from all three of our panelists, so we'll turn to questions. I believe we have, in fact, I know we have at least one, so let me pose it now. The question is, best options for reducing brand name prices? Do issues remain with repackaging, Medicare price fraud? Best options for reducing brand name prices? Do issues remain with repackaging, with Medicare price fraud? That's the question. Would anybody like to comment on that?
Well, this is Dana. I'll take a shot. I honestly don't understand what Medicare price fraud is, unless perhaps the only thing I can think of maybe is Medicaid best price and how accurate that is, the manufacturer reporting. And, that's always been on the honor system. There is very little validation of what goes into a calculation of any particular manufacturer's best price calculation in any quarter. And then repackaging, I think everybody who touches a drug through the whole, it's called like the supply chain, from the point at which it leaves the manufacturing plant to the time it gets to the consumer, everybody takes a margin on that. And repackagers are just part of this system. I mean, they have to have some source of income for what they do. So I don't know that it's a significant thing. It's just, again, part of this system.
Very good. We have another question. Any data on exclusive formularies, it says formularies, having adverse impact on patient outcomes or cost due to denial of doctors prescribed alternate brand name drug of therapeutic class denied by exclusive formula? I talked to my kids about how we're raising a whole generation that has a challenge with plain, clear English because they communicate by text, and I think that that's coming through now in some of our chat language here. Let me try reading this again. Any data on exclusive formularies having adverse impact on patient outcomes costs due to denial of doctors prescribed alternate brand name drug of therapeutic class denied by exclusive formulary. Would anybody like to comment on that, translate that, or pontificate on something wholly unrelated but modestly responsive?
Well, this is Kip. I'll be happy to take a shot. I think the question's referring to formularies and patient access. So while I don't have a specific data point at my fingers, I will comment and I say I don't think there's any question that that formularies and preferred drug lists do impact patient access. They're part of the system that we have. They do play into this marketplace that I had referenced where there's some back and forth with negotiated rebates and so forth. But certainly patient access can be held in the balance at times for this. And so I think from our perspective at pharma, what's important is that there's a clear understanding of how patients are to get access, of how tiering and preferred drug lists and formularies work, and what the exceptions processes are. We see all too often that patients, and this is particularly clear after passage of the Affordable Care Act, when we had previously uninsured patients who were going out and selecting plans on the exchanges, all too often the patients were going out and immediately gravitating toward just the plan with the lowest premium. And in many cases, I think because there was a lack of understanding about drug benefit structures, about formularies and preferred drug lists, patients didn't necessarily choose, in many cases, the plans that were best for them. So I think insurers need to be as transparent as possible to put the language out there, the benefits out there in a clear, understandable way, so that patients can essentially understand what it is they're getting for their premium dollars.
Very good. Anybody else wish to comment on that? We have another question. Does a cash-paying customer at a pharmacy have to pay full list price of a prescription? Fine question. Who'd like to comment on that?
That's a complicated question, but I don't know if Kip or Jeff want to take a shot at it. No.
Yeah, this is Kip. I'm happy to give a couple comments, and others can chime in. at Pharma, we've always encouraged patients to shop around, particularly cash-paying patients, because there's a tremendous amount of variation from one pharmacy to the next. Even the pharmacy down the street is very often offering a product at a substantially lower price. So I think patients are always wise to ask, even outside their insurance benefit, how much the product would cost if they weren't using the insurance benefit. We've heard increasingly of some of these stories where the way the benefit is structured, the patient has a high deductible or a flat copay. They could have a $100 copayment, and it would turn out that they could fill the script a lot cheaper if they just paid cash. And we've even heard some instances where there are contracts between pharmacies and PBMs where there's actually a prohibition on pharmacists to disclose these cheaper alternatives to the patient. We think is really doesn't feel right. So I think free flow of information and shopping around would benefit patients.
Yeah, and I wanted to just back up what Kip was saying, which is, there is a lot going on this space. It has come to the attention of state governments, and they are starting to ban these gag clauses, basically, in PBM and pharmacy contracts. And pharmacists, PBMs are a quite consolidated industry, like wholesalers, and they have a lot of market leverage over pharmacies in terms of you need to be in their networks in order to survive as a pharmacy, and then you have to take these clauses. But states are starting to outlaw them. And then, yes, there's, again, these perverse incentives in the system. I mean, sometimes it is not to the patient's interest, but to someone else in the supply chain, their interest that a brand name gets dispensed over a generic, or a more expensive brand over a less expensive but potentially equally effective for the patient branded therapeutic alternate. So you always need to ask, and ask with my insurance and without my insurance what I would pay.
Very good. Any other commentary or discussion on that subject, that question? We have another question. This one is directed specifically to Kip. Kip, what are some of the policy options to address the PBM concentration you outlined?
Sure. Well, we've been doing a lot of work at Pharma to help the public understand how PBMs work. Because admittedly, this stuff, even for those of us that do this every day, it's complicated. It's evolved into this really complex system with lots of different stakeholders, and we actually put together an analysis. We call it Follow the Dollar, which is on our website, pharma.org, which helps track in various scenarios how the dollars flow through the system and sort of who's holding on to what. So I think that the PBM piece of this has probably for some time now been the least understood piece of the puzzle, so to speak. But I think that the appreciation and understanding of it is increasing. With respect to policy options, a couple things that we've been looking at. We just think that if a patient is going to be charged more for a drug at the pharmacy under the benefit than the insurer or its PBM has been charged, then the patient should know that. So there should be some sort of a disclosure about that difference. And similarly, since there are all these rebates involved, I've given some of the examples where patients are paying a deductible or paying coinsurance on a price that doesn't reflect the rebates. I think we need to consider policies potentially that would require some of those rebates to be shared with patients.
Thanks, Kip. We have another question that's come in from one of our participants. What percentage of drug reimbursement for consumer use is through PBMs, through insurers, or through any other source? So how does it break out? What percentage of drug reimbursement for consumer use is through PBMs, what percentage through insurers, and what percentage through any other source? Anybody want to tackle that or comment on that?
So I think with the advent of the Medicare Part D program for seniors, most people get their drug coverage through some insurance program like Medicare or Medicaid or the VA or your employer. And PBMs operate at the behest of, they are contractors to insurers. So although they have their own sort of niche and, you know, added flavor to the Byzantine nature of the industry and the marketplace, they are operating for insurers, running the insurers' pharmacy benefit, paying the claims, putting together the pharmacy network and things like that. So I view them as, if you're talking about paid claims and who gets coverage where, that is like one bucket.
Let me give you, we're at the end of our hour here. We have one other question here. It's related to that one, so let me put it on the table, see if there's any comment, and then we'll wrap it up. What percentage of drug cost is attributable to wholesalers? Anything on that, or should I have wrapped it up prior to that question?
This is Jeff. You know, from the data where we looked at the top 100 prescribed generic drugs, which is a huge volume of drugs, we saw that on average, the generic was selling to the wholesaler for about 10 cents a dose. The wholesaler was then selling to the pharmacy for 12 cents a dose. So that's a markup of 2 cents from 10 cents. But then the pharmacy was then selling at cash price for well over $1. So I think it's fair to say that the wholesalers aren't adding a tremendous amount of cost here. I think, you know, from the data on the top 100, it's the retail side which is adding the most on the generic side.
Very good. Well, thank you for that. Jeff and Kip and Jane, I want to thank you for taking time to share your expertise as panelists with our participants. To everybody who has been on this webinar, thank you for participating. I hope it's been useful. I know I've learned a great deal from it. I want to thank CWAG for organizing this and make it happen. And of course, I'm grateful to NAG for allowing us to have a presidential initiative that has this subject matter under its umbrella. So wish you all the best. Thank you, everybody, for participating. And I'm sure we'll talk to you again soon. Have a good day.
Thank you.
Thank you.